Hello, everyone. We're going to take about a minute or two to let people join the webinar, and then we'll get started. Thank you. Hello and welcome to the Myositis Association's Ask the Doc webinar series. I will be your host today. My name is Rachel Bromley. I am TMA Senior Manager of Patient Education, Support, and Advocacy. And today it is our honor to have with us Dr. Latika Gupta. Dr. Gupta is a rheumatologist and immunologist in the UK. She leads a number of research initiatives, including leveraging social media as a tool for collaborative research and educating patients, devising a training module for assessment of myositis patients, building a biorepository of myositis patient data, exploring ethnic differences in myositis patients, and more. She is passionate about improving access, quality, and equity in rheumatology care globally. Dr. Gupta, welcome. Thank you.
Thank you, Rachel, for the very kind introduction. It's a real pleasure to meet the team and all your members.
Yes, we are excited to have you. So what we're going to do today, if you've got any questions, go ahead and put them in the Q&A box at the bottom of your screen. We have some that have been emailed in, and then we'll take some live, and we'll just have our Ask the Doc as we normally do. But first, Dr. Gupta, did you want to talk a little bit about your work?
I think we have talked a lot about my work already, but I would love to know the audience because it's been a while since I met all of them before. I think we've met them last in 2020, probably. And I know there are quite a few healthcare professionals, some are researchers, so we have people from diverse backgrounds. And so the myositis patient family, or the community, as we could say, they really have some expertise there, and it's very good to know like who is asking the question really and what perspective they're coming from. Sometimes it can be the caregiver or the patient themselves. So I'd love to just hear in the chat as to whom we're meeting today.
Yes, if you would please put in the chat if you are a patient or care partner, and also where you are calling from or tuning in from, because it's so nice. Dr. Gupta is in the UK. I'm in Columbia, Maryland. It's always nice to see where everyone is tuning in from.
Brilliant. So Kim is IBM from Denver. And if you are a professional of any kind, feel free to put that in as well.
Okay, we've got Denver, Massachusetts, Connecticut. So far, all patients.
Of course, I was in
New
Massachusetts last
York.
week. I visited my aunt in Boston. Loved the place.
Yeah.
Chicken. What's CO is Connecticut?
It's good to see you. Okay, so we have some questions already. So let's see. I have dermatomyositis for about 12 years and take Enrom and do good with it. I have arthritis in my thumbs and have taken Celecoxib for several years. I am worried about side effects after so long. I take it with meals, but it doesn't seem to be working as well. What do you suggest?
Okay, so first I'll need to understand what is Emron. Is it paracetamol? I think it's a trade name. Celecoxib is an NSAID. And okay. So yeah, if you have DM at the age of 12 years, you've had it for 12 years, and the arthritis may not be active disease. I'm presuming it's damage since your doctor has prescribed celecoxib. And Let us just look at Emron. Does anyone know what Emron is?
I don't know. It may have been a typo. I'm looking it up if this person wants to add more in the.
So yeah, so arthritis and myositis can be, different kinds really. And even with dermatomyositis, it could depend on the type of antibody you have. And if you've had it for 12 years, it also depends on your age. But in the elderly, sometimes it's osteoarthritis, in which case it's degenerative. And paracetamol would suffice. Celecoxib typically use, you know, um, if there's inflammation there, and as and when you need. So if you're worried about the side effects, I'd suggest getting in touch with your GP because sometimes it also depends on the interactions, other comorbidities. You take it with meals, which is very good. It doesn't seem to be working. So I would get in touch with the GP and the rheumatologist and take a look at the joints. If it's active inflammation, then maybe could try immunosuppressants.
Thank you. This person carries dermatomyositis antibodies. Their muscles will lock periodically and they have muscle pain. This can go on for months. Their doctor says it is not the DM because it goes away. What are your thoughts?
I know, I read this question earlier and I was like, this is such an interesting problem to have because I did have one patient once in India who had this. And he was a young gentleman who presented suddenly and had rapid worsening. He had DM, and we managed to bring him back to almost full strength after weeks and months of being in a wheelchair. But eventually, he would have these strange muscle cramps or his muscles would lock. And this was his consistent, just the residual problem, which doesn't fit into the DM profile at all. And it's not described in books. And, if I put on my immunology hat and wonder what this is, so there is some muscle damage and there is inflammation, which has resolved. So, whenever there's inflammation, there are animal studies which have shown that even before inflammation comes in, there are some metabolic changes in the muscle, and those can sometimes cause low energy levels, low phosphate levels, which reduces muscle strength. And there is some intersection in the myotonia spectrum disorders as well, which have these. So one, I would say get a neurologist opinion to keep it simple, to rule out anything else that may be leading to this. But if there's nothing else found, then I would just, dismiss it as a residual effect of damage. And from a treatment standpoint, I think it's more on neurologist domain, but avoid activities that promote cramping or, precipitate worsening.
Thank you. This person that's recently been diagnosed with DM would like to know more about how to treat their itchy scalp.
Yeah, again, we have very good problems here, all difficult ones in dermatomyositis, and you really need consistent care for an itchy scalp, and it can be very annoying as well. So, of course, there are oral antihistamines which you could try. There's some topical ones as well, but then really the key would be treating the cause. So if it's active DM, then it's inflammatory and topical steroids, tacrolimus is quite effective. I have given it to a few people. And then if you have really refractory active disease, then it will be you have to go down the immunosuppression route. But sometimes it can be related to dry scalp, which often in DM would be, in cases with damage, long-standing disease and damage, in which case it's mainly emollients and, supportive care, trying to not let it get dry, avoiding drugs that can make it dry. If there are any irritants or you think you're allergic to something, that is another. Sometimes it can be contact dermatitis, something unrelated. So that would be worth exploring. Rarely, dermatomyositis can have, itchy scalp with scaling, which can be, again, a different form of rash. And if you have that, then it is very much, again, would need immunosuppressants along with emollients, and would need a really good dermatology opinion and keeping them in the loop as well.
Thank you. This person has antisynthetase, EJ, and ILD. They are stable due to Rituxan every 6 months. They take Plaquenil for muscle pain. They still have muscle pain, specifically with thighs and upper arms, but frequently just all over fatigue. Their CK level is always normal. Their rheumatologist and pulmonologist suggested IVIG. What else would you suggest?
Yeah, so again, one of the problems that is very hard to address, fatigue, and it's very important to understand that fatigue can be attributed to different reasons, and you also have muscle pain, which again may or may not be related to the myositis. And I wouldn't bank only on CK, because CK can be normal in 1 in 5 individuals, and especially in EJ positive disease, sometimes CK may be normal. So I would look at your AST, the liver enzymes, which also come from the muscle. And if they are normal as well, and your MRI of the muscle is normal, then I would think that, okay, maybe there is no muscle inflammation really. An EMG can also tell you if there's muscle inflammation, but it's not the best test. I would prefer an MRI over it. So more muscle enzymes, MRI of the muscle to see if there is any muscle edema or inflammation. And if it is not there, then this pain and fatigue probably is unrelated, or it is related to the disease, but not due to activity. This deconditioning, or it's fibromyalgia, which can happen in people who have comorbidities. So with the COVID study, we did find that people who have associated comorbidities, they tend to have higher fatigue levels, more pain levels, and the treatment then would be very different. Always worth exploring with the GP that you don't have anything else, like, iron deficiency, vitamin deficiencies. If all of those are normal, calcium is normal, then I would just treat it like fibromyalgia, for which graded exercise therapy is very good. Focus groups, pacing, and working on the deconditioning bit. It's a tough battle really, but rewarding in the long run with persistence.
With the NXP2 antibody only, is it recommended to have a prophylactic ovarian removal if postmenopausal, considering the efficacy of screening?
So again, tough choice. It depends. We have to involve a gynecologist there. Of course, we have new cancer guidelines, but if you dig deeper, how guidelines are made, they're based on evidence. And how is evidence generated in a disease like myositis, which is rare? We are not able to cover all regions. We're not able to cover all kinds of myositis or enough numbers. So these are really the first set of guidelines. According to them, yes, if you are DM and NXP2, then we have to do an extensive screen. Now the question is the cystic ovary looking cancerous or not? And there are specific criteria for that. Off the top of my head, I read this more than 15 years ago, but the thickness of the walls of the cyst. So I'd say seek a gynecology review. There are tumor markers that can help and support the decision. And of course, the gynecologist needs to be informed that this is high risk for cancer, but it's not absolute. There are other factors involved as well, like your age, gender, ethnicity. These will become very important because what's the background prevalence of ovarian CA in those populations? Do you have a family history of CA? So then I would say it boils down more to a personalized decision. And I wouldn't go on any blanket guidelines to, go treat it. Because it is an open surgery, or even if laparoscopic, it can cause some morbidity. So shared decision making with yourself, the rheumatologist, and the gynecologist would be the best way to go with.
Okay. This person has DM and has been on CellCept for 20 plus years. They're on the highest dose now, 1,500 milligrams twice a day. Is it safe to be on this drug so long? I was diagnosed with DM in 1995. I also have rheumatoid arthritis, Raynaud's, Graves' disease, Calvino is in my finger, osteoporosis. I'm told that I now have a scleroderma because my DM morphed into that. Do you have any suggestions for a better treatment?
So the first question I would ask is because autoimmunity tends to wane with time, and I don't know how old you are, but sometimes the disease really dies out with time. Not in everyone, but depends on your disease as well. Was it monophasic, or did you have several relapses? And then if it has morphed into scleroderma, again, I'm inclined to think it's fibrosis taking over. And when that happens, then often you don't really need treatment. Regarding arthritis, which you seem to have arthritis, MMF is not the best drug for arthritis. So it depends on the disease condition, and if you think you've been in remission for a very long time, then maybe worth considering discussing with a rheumatologist if you can taper it off. What to give, again, depends on which of the diseases are active, since you have a bunch of those. So it would boil down to, a few choices, factoring in the other autoimmune comorbidities.
Someone put in the chat that that first question was probably about Imuran, which makes sense. And so they were worried about side effects from taking Imuran for so long. Do you have any guidelines for that?
I don't think there are any guidelines for that because with Imuran, that is mycophenolate, and it's azathioprine, you mean? No. Imuran is azathioprine, right? I think. Either way, for both azathioprine and mycophenolate, there are no guidelines and there are no limitations to use. It's with methotrexate that the debate goes on because, gastroenterologists don't like to give it for too long and rheumatologists just like to give it lifelong. But with these two drugs, there's nothing that I've come across, and there's regular monitoring with blood counts, liver markers, which usually suffices, and I'm not aware of any long-term toxicities of these two drugs. If someone is active, I wouldn't shy away from continuing them if they're responding to it.
This person says that their dermatomyositis was diagnosed after getting the COVID vaccine. Have you seen patients in a similar situation?
Yeah, and funnily enough, I thought today was a talk on COVID and myositis, so I had my slides ready. But I'm not going to bore you now with those slides. But we did have a few patients come up. Now the big question was, was this just by chance, or did these people have some background genetic, predisposition? And with the environmental trigger, that's COVID, it led to DM. I'd be very curious to know what kind of DM you got. We had a few reports of MDA5. But honestly, this question statistically and epidemiologically, it can only be truly answered by population level studies. The only studies that have come out from Scandinavia so far, they were not focused on myositis, they were focused on just autoimmune conditions in general, did not suggest that vaccines are causing any new disease. But we surveyed all of you, and there were a few people who reported new onset disease. So out of 20,000 people, 600 said they had something, 300 consented for a follow-up survey. Out of the 300, around 115 responded, and of them, 75 seemed to have some condition. And out of the 75, 25 had myositis. Now, there was obviously a bias in this survey because we're specifically, looking for information in myositis support groups. So there are instances where people have reported these, but it's very hard to say unless we have data from Scandinavian countries. Until now, the few studies that have come out do not suggest that these have caused myositis.
This person has been using homemade organic CBD infused coconut oil for back muscle pain and spasm, successfully eliminating all pharmaceuticals for 3 years. But then 5 months ago, diagnosed with DM and now taking Plaquenil, methotrexate, and Zyrtec. Have the anti-inflammatory benefits of CBD been studied at all with DM as edible and/or topical methods? Any studies of THC cannabis infused topicals for rashes?
Not aware of any specific studies in DM, but I think there were some ongoing studies. And CBD receptor has been shown to be on immune cells as well. I do think that the effects will be mild, but the perceived benefits will be manyfold, higher because it can impact perception of pain. But yeah, it'll be good to look out for those studies.
And I also want to remind everyone to please, if you have questions, put them in the Q&A. It's harder for us to find them in the chat. Our next question, this is a patient in the UK with DM. And could you please tell them what the criteria is for accessing rituximab in the UK? They were only able to get it once in 2022, and it was incredibly beneficial. But despite ongoing flares with muscle weakness, they've been unable to get rituximab again. The consultant wants to see evidence of inflammation. And by the time that these investigations can be done, it's usually several months later and the flare is over. Her CK doesn't rise during a flare, and they have a borderline response to steroids.
So the criteria for rituximab use include demonstration of a visible benefit in terms of muscle strength. I'm not sure what the initial MMT was and how much
The
it improved.
the MMT8 score was 108.
And this is before rituximab or after?
This is after, and then they weren't giving them the rituximab again.
It really depends, how much I'm hearing after it went up to 135. I usually use the MMT80, so if we divide it by half, it's around 60. You see your strength did go up significantly, and 115. Can I ask you, Rebecca, like which center you're at? Because sometimes it's a commissioning policy and the funding for rituximab can be limited, and it's hard to acquire it. You need approvals from a tertiary care center. So maybe we just need to talk to the tertiary care center again. And sometimes you're in Devon, and so you'd come under. So what's your tertiary care center? I'm not sure, but maybe it would be London or Bristol. Bristol, yeah. So maybe it will be worth your consultant discussing with. I think it will be Harsha looking at your muscle, and sometimes I use MRI of the muscle to support because if they are not convinced, but I've had patients where approval was given for even lesser improvement. So I'm not sure what happened in this specific case, but it may be worth initiating a discussion or seeking, a second opinion at a tertiary care center if you haven't been there yourself. Sometimes, there can be confusion in the whole like third person discussions. Or if there was some other contraindication, sometimes those come in as well because there's a whole set of policy. But these rules are available online. So if you search the rituximab commissioning policy for myositis, it is searchable online for NHS England. So you would know everything about your case best, and you can see the criteria online, and that would be helpful in informing the discussion with your consultant. And you always have a right to seek another opinion or go to tertiary care maybe if you think those criteria are being satisfied.
What are better alternatives to Prolia? They have multiple fractures in back from a recent fall. They have polymyositis and ILD.
So again, this is one very important aspect of health that is often ignored in myositis. And in Indian patients, we had found that 46% had asymptomatic vertebral fractures. And when 3 years later we looked at those fractures, then we could only X-ray 30% of them, but they had increased. So clearly, if there are fractures, they need to be treated. There's no separate policy for myositis. In particular, the data is very scant again. So we have recently just submitted a paper which is under review, where we again looked at service needs for osteoporosis. In England, we follow the standard osteoporosis pathway. If the patient is on steroids, then the FRAX calculator does ask for it, and it accounts for the fact that you are on immunosuppression and you may be at a higher risk. The other factors that inform the decision based on the FRAX score is, whether your family ever had a fracture, parents having a pelvis fracture, if you smoke, your weight, the BMI. So these are factors which inform the decision. And then based on, the FRAX score, it gives you 3 different zones. And if you're in the red, then you need treating. If you're in the green, then it's watchful waiting. Usually with a fracture and underlying DM, it would qualify for treatment. But the guidelines are very different in every country. So we follow the American system in India. And trust me, it's been 3 years, but I still struggle to understand the British osteoporosis pathway. And it's changing very quickly. We have newer drugs available. So again, it would depend on your individual situation.
This person has been going to a rheumatologist for IBM for 26 years, and now they tell me that I should go to a neurologist. What is your opinion?
So I'm not sure what the conditions of your treatment were because, the landscape. I'm just assuming that you were diagnosed previously with polymyositis because the two diseases can look very similar. And if it's been 26 years, I'm also assuming that you were diagnosed when you were younger in an age group where IBM does not usually happen. But I think we'll need more details to say what happened exactly. IBM, yes, it is managed by neurologists. Polymyositis is managed by both, but typically rheumatologists because they do try to treat. And once you have a diagnosis of IBM, the options are very limited.
What causes thighs, hips, shoulders, burning, and pain? Will the pain and burning go away? Is there a medical name for this? How does one measure muscle mass loss in legs, thighs, and shoulders?
So I thought you asked about pain first. So burning, and burning can be, different reasons. Again, we'll need to look into it further. Specific burning in this region is odd because generally burning involves the extremities more than, shoulder girdle or pelvic girdle. Fibromyalgia can also cause a burning sensation. So it depends really on what the character of burning is, and it would depend on a detailed history and examination. In terms of muscle mass, there are many different modalities. Again, it depends on what you want to look for. If it's for myositis, then I just use MRI. And there are tools now, qualitative and quantitative, semi-quantitative scorings to look at, fat, edema, and even muscle mass. But these are not fully standardized, or these are not some things we use routinely. It's not a rheumatologist area, really. It's more under radiology, or they use that a lot in pediatrics where muscle mass is important, or in geriatrics, but not so much in rheumatology.
This person wanted to know if it's just a difficult question. They said, thank you for answering my question about having DM, antibodies, and muscle pain. My doctor says it isn't DM. Is there a clinic in the United States you would recommend?
I know that Dr. Didem Sagan has a special interest in myositis and also in pain. She's currently in Pittsburgh. So yeah, I don't know much about the US, who's interested in what, but I do happen to know that she's interested in this area. If you want to contact her.
Okay, and this person has polymyositis. Their CK numbers are normal now. However, they still routinely experience muscle pain. My doctors tell me it isn't because of my polymyositis, but I don't have another explanation. Can it be related?
Yeah, and unfortunately, pain is a very understudied aspect of myositis, and we did find this in the COVID study as well. When we asked people, a cross section of myositis population, 1,500 people, how much pain do you experience? It was higher than people, healthy individuals, and it was same as most people with other rheumatic diseases. So I feel it's an unexplored area and something because the physician is so busy dealing with more challenging issues like muscle weakness, loss of the ability to, do your daily activities. So I think pain is one of the components of myositis. It depends when you're having pain. Is it during the active phase of the illness, in which case the pain could be part of myositis, or if it is when you're in remission, then it could be just deconditioning or fibromyalgia, or it could be something else. So it depends on the situation.
Okay, what percentage of patients with DM do not have a CK rise?
DM, it depends on the type of DM. So people, particularly with antisynthetase syndrome, the non-Jovan category, there are quite a few who don't have a high CK. Typically, overall in myositis, they say like 20%, up to 20% can be normal. Now, the definition of normal itself is so abstract because there are studies showing that in different ethnicities and different muscle masses, the cutoff can be different as well.
What is the best way to diagnose a flare of DM?
Again, depends on what you have. If you have rashes and muscle weakness, then those are the best indicators, really. And if you have something like NXP2 or MDF5, cutaneous ulcers could be it. If you have MDF5 or antisynthetase DM, then it could be ILD. Sometimes mechanics hands precede a relapse. So that could be one feature. In Jovan positive disease, there can be fever. So it depends on the type of disease and what you had when you first manifested the condition. And oftentimes, the phenotype stays about the same, except sometimes, as one of you said, that it evolved into scleroderma, which is not very common, but it is described. And arthritis as well, that can be an indicator of flare as well.
Okay, someone with IBM is losing weight and she or he feels this is due to losing muscle and wants to know how normal this is.
So I've noticed a lot of patients with necrotizing myositis, they lose weight because they lose a lot of muscle over a very short time. So, over weeks, they just lose a lot of their muscle, and that accounts for weight loss. If you have cancer, then cancer-associated myositis, and of course, it could be due to cancer. But in other types, it's not that common. Sometimes, if it's scleroderma spectrum myositis, then scleroderma causes atrophy of fat, and that can cause weight loss as well.
Okay, it looks like we have just one question left. Have you noticed eye issues with myositis patients? I've had numerous eye surgeries and other eye issues since diagnosed with myositis.
So what is the question? It's about what
Eye
percentage have an eye
issues.
problem?
Yes, and I don't know what the
Mhm.
eye surgeries were for, and I'm not certain what the eye issues were, just since they got diagnosed with myositis, they've had a lot of problems with their eyes, and I guess they're wondering if it's related.
Yeah, so again, something we did look at in the Indian cohort, retinal changes, but in general, it's mostly cataracts, and the heliotrope rash is very common in dermatomyositis. But other things are very rare, and we also formally studied this, and we found the same. But I'm not sure what the surgeries are for. It could be related to a comorbidity, maybe, or if you have scarring in some forms, you can have cutaneous ulcers. then those could, need surgeries. And sometimes people have severe dry eye, which can need a punctal plug or something. So, but in general, it's not very related. It's not a strong correlation.
This person has DM, ILD, and hyperlipidemia. If they get COVID, should they avoid taking Paxlovid because they take Celsep, prednisone, colisvelum, Vascepa, and Repatha injections?
So if you are in England, I think you'll qualify for sotrovimab. Again, there's just pathways for everything, but generally people who have are on immunosuppressants or have DM, if they get COVID and on day 3 we feel that they're worsening, then we admit them for sotrovimab infusion. I think Paxlovid is second line, as far as I remember. But we are not getting much COVID now anyway. At least not in England, or we are not testing. I don't know.
How often can you have rituximab? Is there a limit? And does it have long-term effects on the circulating autoantibodies? Is there a case for routine prescribing to prevent flares?
I think Rebecca is a doctor, isn't it? Her questions are medical. Rituximab, Rebecca, it's ideally given 6 monthly. Now there's no guidance for it because no formal criteria of relapse in myositis as well. So, that's how the guidance comes in. But typically for most conditions, it's given 6 monthly. Since you're in England, the NHS commissioning criteria is that you wait for the patient to relapse and then you administer it. The long-term effects in circulating autoantibodies, I don't think long-term has been studied. Short-term, it does impact, it brings them down. So I think there's data in Jovan positive myositis, and there is data on, I think, Rho52 maybe, and MDF5. Routine prescribing to prevent flares. Yes, in healthcare systems where that's okay. I don't know about the American healthcare system, maybe German. I think, some places, like even in India, we gave it 6 monthly. But it really depends on the healthcare system because the regulations vary, and this is a gray area. But if your disease tends to flare again and again, then I would be inclined more to, call you in at 4 months and see if you're developing any mild features of flare and then re-infuse. That's what I do.
This was a complex case diagnosed at 19. Now the patient's 23. No myositis antibodies, no family history, no other diagnosis. It's advanced and aggressive. Currently on IVIG monthly for the past 2 years, Celsep for 16 months. Now IVIG monthly plus rituximab, which has been 2 infusions, 1 times 6 months. Just added methotrexate. Any other ideas to explore?
You have tried most of them. Azathioprine would be one, depending if you have rash, hydroxychloroquine, but that's a weaker drug. JAK inhibitors, again, depends where in the world you are and if it is, approved for arthritis. If you have arthritis, then it could be tried. Yeah, I would also go and relook at your case because no antibodies, no family history, no other diagnosis. Diagnosed at 19, so relooking at the biopsy, second opinion. There are newer antibodies described since then, particularly for younger people like FHL2 and others. If it's severe and aggressive, I would explore those. Yeah, I think that's about it.
How long can you be on IVIG?
Again, there's no guidance for it, but then if you're a severe case, I'm sure your doctors can, seek special permissions. Depends, like in England, it depends if you're requiring hospitalization, then there's an individual funding request that can be made. And then there are people on a panel who either approve or reject it.
How much vitamin D is best to take? And do you have any other recommendations on vitamins?
So, routinely, depending on your age, your requirement may vary from 600 to 1,000 international units. It's best to test vitamin D levels. If they're low, then it would be worth, if it is low, then depending how low it is, we usually give a high dose vitamin D course, which is around 50,000 units every week for 6 weeks. And after that, we come down to maintenance. Now, vitamin D is a fat soluble vitamin, so it's very important it can stay in your system, so it's important not to overdose. So always consult your GP or healthcare provider.
What is the difference between juvenile dermatomyositis versus adult dermatomyositis?
So I think juvenile dermatomyositis is more straightforward than adults because there are not so many different types. There's usually one phenotype, which is rash, muscle weakness. It's pretty straightforward. Sometimes it can be very severe, especially if it's in a younger person, like under the age of 10, then typically it's juvenile dermatomyositis. It's classic rashes, classic weakness, easy to diagnose, and there's standard treatment to give. It can vary in severity though. So some of the types of adult myositis, they are almost, rare or unheard of in juvenile, like cancer associated doesn't occur. ILD is not that common. So antisynthetase is not common at all in juvenile DM. Anti-MDA5 is less common as well, which comes with severe ILD and severe consequences. Some complications may be more common in juveniles, like calcinosis. I'm not sure if that answers the question, but yeah, this is all I can think of at the moment. In juvenile, if there's a rash, so there's often less confusion around the diagnosis. In adults, in DM, of course, there's a rash, but there can be other types, polymyositis, etc. Where you then have to look at, consult a neurologist as well.
We have someone on the line, the 19-year-old that was diagnosed, the mother is on the line, and she's very scared. And do you have any, when you have patients come to you and they're scared about this diagnosis, how do you comfort them?
So it is difficult diagnosis, and it is hard to make peace with the condition. But then once we understand what's going on, there are also many different treatment options available. And it's really diagnosing soon and then initiating treatment, which is very important in deciding for the course and how the outcome will be. So some people have very mild disease and they just have a monophasic course. So monophasic means it just happens once and then they go into remission. And there are few people who have flares again and again. But even in those, usually you can keep flares at bay with appropriate treatment. So my approach would be really understanding what's going on in which organ, how much is the inflammation, what the individual's coping capacity is, what support do they need. And sometimes it's also very important to understand that the patient themselves are coping with the condition. And then, parents and caregivers, they have their own bag of emotional issues. So it's very important to bring in that compassion for the child or 19-year-old as adult, and also for yourself, and seek the right kind of support, social support, psychological support, read about the condition, but in the right places, because misinformation particularly can be very damaging. And I feel one key message to take home would be that this is a condition where good care and good physiotherapy and family support is extremely important. I've seen this in my patients, people who've been bedbound for 2 months and came out of the condition just because they had the right kind of support at home and from healthcare providers. So consistency is the key, and being worried or being extremely anxious can sometimes prevent you from giving the patient the best that we can.
They are concerned that that the diagnosis could lead to death. Could you clear that up for them?
So it really depends on what kind of condition they have and what they are manifesting right now. Not many types of myositis lead to death. So I would disagree. There are very few types which are very severe and take the patient down quickly. And death is inevitable for all of us eventually. For all we know, we might be crossing the road and maybe no more after 5 minutes, any of us. So I would not treat that as a hard end point that I would be looking at. I would take one day at a time, understand what needs to be done, just do it and see how the situation evolves, which can be very difficult to do. But that is what this condition needs, and that is what your child needs as well.
Okay. Someone is asking, are the symptoms that some people have been mentioning during this webinar possibly side effects of their medication and not necessarily symptoms of the disease? I've had a lot of dental problems. The dentist attributed it to prednisone. And also, I have a couple of torn muscles that we do not know a definitive cause, but the doctor said it could be from prednisone weakening my muscles.
So are they wanting to ask if it's related to steroids? Is that the question? Hard to say in your case, but yeah, if you think it's long-standing, you've used a lot of steroids. Steroids do cause muscle atrophy, and they do cause muscle wasting. The pattern of muscle weakness can be different with steroids. So more calf muscle involvement, thighs as well. Slightly different from myositis. But if there's any way, we should try to minimize the use of steroids if we can. It would be best to discuss that with your doctor.
Could you discuss evidence-based studies on exercise and diet to help with myositis?
So diet, for sure, we know that there's no evidence, but the COVAD-3 survey is looking at that. So if you'd like to support it, please take the survey. We're exploring Mediterranean diet. In terms of exercise, there's a lot of evidence. So Helen Alexandersson from Sweden, Karolinska, has done some phenomenal work in this area. And, in the 1990s, it was thought that myositis is a contraindication for exercise. So people with acute myositis, would ask them to not exercise. And even now, if the CK is super high, then we think, okay, it can cause more muscle breakdown and, it can impact the kidneys. But that's changed now slowly, and over time, people are encouraged to start with slow and gentle exercises, even in the active phase of the illness, and gradually build on muscle strength, go on to weight-bearing exercises, but it has to be timed and titrated to what your body can take. And this is something everyone should have a dedicated physio, and those conversations of upskilling yourself and upgrading the level of exercise you're undertaking. But there's a lot of evidence-based studies.
Does it mean anything if your antibodies disappear after treatment? I was PM75 positive to start with and ANA positive with DM, but now the antibodies are negative after several years of CellCept. Does it mean the disease is going away? I am still getting flares.
So it depends on how the PM75 was measured. There are assays which can look at the levels, but those assays are not widely available. In any case, I wouldn't repeat those levels because I don't think they tell us anything. You treat the patient, what they're having, what their experience is, and antibody levels typically don't guide treatment, except in a few instances like MDA5, where we need to decide very quickly. So we sometimes repeat them, every month. But PM's SCL 75, I wouldn't bother. I would just treat what you have. And if you're flaring, then you're flaring.
This person's rheumatologist is not convinced that they have DM because of blood tests. He mentioned DM does not cause muscle pain, just weakness. Is that true? Is it possible to have the myositis part of DM without high CK or other positive blood tests? I am only 10 months into this disease.
It is possible, but DM by definition should have a rash. You haven't mentioned a rash, so I wouldn't know how
They
you
got a punch biopsy of rash on the knuckle.
Okay.
But they have pain and atrophy and weakness in shoulders, arms, thighs, and hips. Pain and weaknesses during activity and for days after.
Yeah, I often request an MRI of the muscle in such cases. So if they're doing a whole body MRI at your center, you could go for that. Not many centers do it. So if you think your thighs are weak or the arms are weak, you could go for a focused MRI. And that would tell you if there's any edema. Even the pattern of edema can sometimes be useful to see if it is related to DM or if it is something else. Because even in, some dystrophies, the pattern can be different, and we get an idea with the MRI.
The CK is the same during steroid use, but they have a lot of weakness. Can strength be regained with strategic therapy or exercises?
For sure, it is known that muscles don't regenerate a lot, but they do regenerate. And then there's also, the deconditioning component of it, which can be improved. And with physio, a lot more can be achieved than we think. So I would say get a dedicated physiotherapy advice and just go for it.
What do you recommend as far as exercise for IBM? Type, frequency, intensity?
I'm neither a physiotherapist nor a neurologist, so sorry. The wrong person to ask. I will send you to a neurologist.
Okay, let me check for any last minute questions. If you have one, we only have a few minutes left. I'm going to check in the chat to see if anybody put any there. Someone wanted to send out a note to everyone. Just wanted to send much love to the mom, daughter, and anyone who feels the same, who expressed great worry about this diagnosis and fear of morbidity and mortality. Please be comforted that there is a global community of experts and patients like us who have done very well despite a very tough initial diagnosis. Please reach out to TMA or your local patient support group if you ever need any support or help or just someone to talk to. This is absolutely true. We have support and affinity groups, and you're welcome to get on our myositis.org website calendar and jump on the nearest one. You don't have to be from that area. We're just here for you. Someone missed the medication you mentioned to use for scalp itch. Do you remember the name of the medication?
Tacrolimus.
Okay, can you type that in the chat? Because I'm scared to even try to spell that.
Yep.
There it is. Oh, that's easy enough. Okay. All right. Well, thank you so much, Dr. Gupta, for being here today. We really appreciate having you here and you taking your time.
Pleasure is mine. Thank you very
Yes.
much.
All right. Well, thank you so much, and everyone have a great day.
Bye.